You're welcome, Gail.
I'm gonna do this real quick. This is technically Guy's new job, but I've had these things carrying them around. I have 3 or 4 more. John Fulton, step up here just a second. I want to present John with Paul Harris Fellow. He is a new Paul Harris Fellow member of our club, as we all are. He gets a solid gold pen. Don't lose it. John is a member of Paul Harris Fellow now, which means you've given $1,000 to the Rotary Foundation. If you continue giving $1,000 a year, Paul Harris Society member. I'm sure Guy would love talking about that.
Yeah, that is on my to-do list. I'm the foundation chair this year, so we need to add at least one person as a club goal to the Paul Harris Society. There are a bunch of people in here that do it already. Raise your hand if you do. Yeah, so we got a bunch of people that have drank Kool-Aid, so we're looking for our next member. Thank you.
The Paul Harris Society, we did the foundation banquet an hour early for a cash party. So it's a good deal. Anyway, so I can see the disappointment in the room, but I'm going to skip Kahoot today. Move straight to Happy Dollars.
Happy Dollars, baby.
Who's got Happy Dollars?
Come on, baby.
I've got a couple. So yesterday was Mylan's first day in 8th grade. So God bless all of them. But he and his best friend were 2 8th graders that were selected to play varsity soccer for Greensboro. Wow. Really awesome. So we did soccer and travel across and the 5 other sports that he's in. And I'm hoping that he can stay out of trouble this year. And then with my business, I applied to be an exhibitor at Converge South through Flywheel in Winston, and we got accepted. There's some pretty cool things from North Carolina, South Carolina, and Virginia, September 8th and 9th, and it's another small incubator program. So if you guys are part of Flywheel, you might see some advertisements that support your local small businesses.
Just a quick update. Monday, I successfully moved Rosa into NC State. She's settling in. Very excited about the year ahead. And then yesterday, I drove home from Boone without Victoria. And I can't elaborate anymore.
I think anybody who's serving as an angel on earth is set up to what to say. I say, quick, we're all also crying. So one day, about 6 years ago, I drove my son to the hospital, 106.5 degree temperature. We got there, the crash team was there. It was 10 angels on earth. That's our guest speaker today, who saved his life. And my job was to look at his face. They said to me, tell us if he's dying. That was my job. That miracle starts at High Point University this Saturday. It's God bless my hero, inspired to every day to their father and person.
All right. So finally, the secretary got a chance to get over with that. You know, John's standing a little taller today, which is like that. Vince Raphael's official this week.
All right. Hey.
Get him the blue.
Well, Grandpappy Lewis used to say, always remember that the one consistent feature in all your dissatisfying relationships is you.
Just a couple of quick announcements. If you didn't sign up for the family of Rotary, you can still buy tickets online and they're good for a year. So if you want to take your kids out there and ride the carousel all day, September 10th, we have a few signed up. A couple people are going to do the zip line. And it's real busy the next couple of months. There'll be a lot of stuff coming out about big stock. I think Tom Phoenix is going to work with that, and World's Greatest Meal and stuff. So a lot of announcements are going out. So feel free to come to the family at Rotary Day. You don't have to buy a ticket to come, but you can still buy them online if you want to. So I'm going to bring up Steve to introduce Dr. Patel. Get him ready for surgery.
When I was 42, I had my first open heart surgery. I think it was a triple bypass. I can't remember. I had two of them. And about a year later, I was in agonizing pain, neck pain, numb leg and all that. And I went to a doctor and he said, yeah, you're gonna need some surgery. You need some spinal surgery. And honestly, I cried. I mean, it just didn't seem fair. I was only 42 years old, 42, 43. And my wife at the time worked for the hospital down in Florida. And she said, I want you to get a second opinion. So I want you to see a pain specialist. And I went to this pain specialist and he said, that is absolute crock. So I can get you fixed up. And with a couple of injections in or around my spine, I don't know exactly what it does. It wasn't pleasant, but it took care of the problem. And so when I met Dr. Janus Patel a couple of years ago, and he told me that he was an anesthesiologist and a pain specialist, I loved him immediately. So Dr. Patel is currently assistant professor of anesthesiology and pain medicine and medical director of High Point Premier Pain Center. With no more ado, I'd like to introduce him. He's a wonderful man. He's got a beautiful family, a 24-month-old daughter, and two beautiful dogs, and an absolutely beautiful wife. So.
Yeah, great. Thank you. Thanks. Thank you for your time. It's great to meet everybody. Thank you for having me. And I appreciate the time words. That's a job at High Point. So we got to go through a lot, and we don't have much time. So feel free to stop me with questions. That's where the meeting is. I really don't like PowerPoints, to be completely honest with you, because a lot of the stuff is hard to understand without me showing you with a model or something like that. So bear with me, but do ask questions. So here are the goals. I want to demystify chronic pain, and pain clinics. So there's this negative connotation about pain clinics. Whenever you hear that word, it's like, oh, you're just going to get narcotics. There's nothing else. And so a lot of patients come through, their primary care, and the primary care offers them to send you to the pain clinic, and they say no because they don't want narcotics, which it's understandable, but that's not what we do. And of course, our ideal world. Most common issues patients are faced with, honestly, where there's a lot of stuff I could probably talk to you about. So I picked back pain, low back pain, but a lot of the things I'll talk about apply to the neck, the thoracic spine, lots of places. But just to be quick, what I have pictures of that real quick, we'll talk about back pain. Treatments, innovations, questions. So let's demystify them serious. Most people that are living with chronic pain, which choices do they have? Well, most people tell them, doctors, okay, go do physical therapy, go do a chiropractor. And then they come back and they're like, okay, nothing really helped, or I still feel the same. It got a little bit better, but it's coming back. And then they go to a surgeon. And so medications, there are a lot of different types of medications, arthritic medications, nerve pain medications, narcotics. Do they work great? To be completely honest with you guys, I'm not a fan of any one of those medications because it's got side effects. And I think depending on the problem, we could probably take care of that pain in a much better sense without those side effects of medications. So I'm just not a fan of that. Surgery, there's always surgery. And sometimes people need surgery. I am technically an anesthesiologist that does surgery, but not major surgery. So there's a little bit of clarification that I do want to provide there. I do some minor surgery. Now, our surgical colleagues who are trying to take care of the problem, you have a bulging disc pushing on a nerve. How do you make the disc stop bulging? Well, shave it off, take it out, or cut the leg off. But that's not really something we're going to do. But, you know, we have to have the surgeons on board. Just live with it. Now, this is one that we all love to kind of say in our minds. I know I don't like going to the doctor, and sometimes I just live with it. But, you know, part of my job is coaching. I want to empower people that come to my office to listen, you don't have to live like this. And if you don't want to get stuck with the needle, that's fine. But just know I don't want you to leave here feeling hopeless. Whenever you're ready to come back. So back to what is our role? That's kind of the thing we are all trying to redefine. There's been, I'm sure you've all heard the opioid crisis and all those pain clinics out in Florida, whatever, were just dishing out Percocet and really created the problem. That was then. And now we have interventional techniques, and we're refining these interventional techniques. And I'll get to kind of how I treat pain from that. So I'm going to go through this fast. This is just some stuff, but the most important thing is prevalence in the U.S. It's hard to really know prevalence, but around 13 to 21% of U.S. adults have chronic low back pain. And that's defined as at least 3 months. Lots of strong associations with back pain and chronic pain, but one of the major ones is nicotine tobacco. And any sort of nicotine ultimately makes degeneration, arthritis, whatever, makes it get worse faster. Doesn't truly cause it, but it will get worse faster. My approach to treating pain. So this is how I do it. This is what I tell people. What area of pain? Most people have 5 things on their list. So to shave the little man that we give them on paper, the whole thing shaved. I'm like, okay, this is not good. What area of pain bothers you the most? What disables you? What can we do to get you moving better? Can you not wash dishes? Can you not vacuum, cook? What is it? Describe this pain. Now, this is the toughest question. People come in and say, you know, I've got neck pain. My doctor told me it's a bulging disc. Okay, I don't care about that. What does it feel like? What does it feel like that bothers you specifically? Functional limitations, weakness, all these things are important. So another part, and this is a hard one, another thing I try and teach patients is to retrain them to think about their pain, give it qualifiers, really narrow down what they're feeling. And then the next time they come in, boy, I've got a plethora of information to go by. And it does work. Find all the sources. Now, this is the key. You have a bunch of pain, find every source, every etiology. Make a list, and that's exactly what we do. Now, I rank each source, and this is my job. Ranking everything based on what we think is the most problematic source. And that sometimes that can be tough, but for back pain specifically, or neck pain, it's not that hard. And then you go after each source individually. And I then tell people in the course of the next 6 to 8 months, my goal is to get you 50% of their pain that lasts. And usually it's more than that. So this is just a little anatomy lesson because things will make more sense. So now it's the kind of the fun stuff, the pictures. So here's an MRI of someone's low back. Here is just an X-ray and another X-ray from the side. Everything I'm talking about applies to the entire spine. It's just easier to have pictures of your low back. And you can't see this terribly well, but what we have here, what I want to point out are a few things. In your spine, you've got holes, you've got discs, you've got joints and bones. And that's the basic structures. Those are the basic structures that could cause pain. So I try and simplify this as much as possible for the layperson. If you come in with back pain, it's going to be a few things. It's either going to be joints, it's going to be discs, muscles, or maybe you had a back surgery or something in the past and you can tack that on this. And then I just rank that stuff. You've got discs here, they're like the shock absorbers. There is a hole right down the middle where nerves travel. And those nerves come out of little holes on every side, on the left and right side, at every single level of the spine. Those nerves go down the legs. You got joints as well, because these bones have to stack, these vertebrae have to stack on top of one another. Where they touch is a joint. That's usually right there, both sides, all the way up to your skull. And then you got one big joint here, and that's called your sacroiliac joint. I would say 95% of people that come in with low back pain is related to this joint, number one, and then the tiny joints, the set joints, right there. You take care of both of those, most people feel better. And that's what I'll talk about how we do that. So back pain, pain down the legs. You got back pain, you got pain down the legs. Separate the two. That's what, it's really difficult for a lot of people to try to understand that, but it's basically an electrical system of nerves. If you have pain down the leg, it's connected to nerve. Back pain is all that other stuff I just mentioned, discs, joints, bones, whatever. So the treatments are totally different. And when Steve was discussing the story, I had some injections around the spine. There's about 100 different types of spine injections around the spine that I have to do that not all people can do. And so when someone comes in and something for the first time, I've had that before. And I asked them the specifics of that. What did you have before? And they don't really know. And so I just have to disregard any prior issue. And that's sad because it could have worked. To make it quick, pain down the leg. That's like sciatica. We've all heard of that. It's just a pinched nerve. Anytime you pinch a nerve, you can pinch it where you pinch a nerve matters. You can pinch it at the side holes, which I showed you in the previous picture, or you can pinch it in that center hole where all the nerves have to travel before they exit. So think of it like this. In your back, you got an interstate and there's exits. You have sciatica, pain down the leg. That means you're pinching off an exit. If you have something else, which we'll talk about, the better way to phrase it is what happens if you pinch the interstate? And this is something that not a lot of people can figure out and not a lot of people know what to do about. So we'll get to that. Epidural, we've all heard of epidurals. So an epidural is a space. It's all it is a space that surrounds nerves. You can put anything in that space. You can put saline, steroid, wire, catheter if you're having a baby, so on and so forth. But when you have a pinched nerve, that nerve will get angry, it's inflamed, swells up, and it shoots off its pain signals. And then it builds up all these chemicals around it. And our goal with an epidural is twofold. Reduce inflammation with steroid, but put the steroid where the problem is, coat the nerve. As well as flush out all those chemicals. So at the same time, we'll follow that. So, look at all that stuff. Here's an example of an epidural. So what we see here is X-ray image of the low back. And I'll only put one picture up here. Here's the needle coming in, and it's going into one of those holes. Also, holes right there, and those nerves, those holes. So that is an epidural. You can see right here contrast. So we inject in contrast to make sure we're in the right spot, and it outlines the nerve. And here's another better picture of that hole. So that is the first and foremost treatment. A lot of people ask, okay, how long is this supposed to last? Beats me. I always tell people that's the magic of that question. I don't know. You be the judge and tell me. I hope you get 3 months. That's the goal. If you don't get 3 months with the steroid, any steroid, then it's not worth it. You can try it one more time, but if you get the same result, something else is done. That's what we're talking about. So I do want to bring this up because this is something a lot of people have, nobody knows about, or nobody knows how to accurately find it, tag it. So I have one question I ask people that have narrowing of the central canal. All the nerves have to travel. And your spinal cord ends right there. So it gives off a horse's tail of nerves. And if you narrow that central canal, that's what it looks like on the MRI. It's supposed to look like this, white, dark, thin strip of light. As you can see right there, it's narrow. But what does it feel like? It feels like when you you walk a long distance, your legs feel heavy, achy, crampy, like jello, like you're gonna lose your balance. Really worse when you are walking uphill or upstairs, and better when you sit down or lean forward. Now, you go to the mall, you go to the grocery store or Walmart, you see these old walkers. They have to have a walk. They have to have their shopping cart to lean on, to walk. And you ask them, why are you doing that? What's the problem? Why can't you walk? And you say, oh, I just feel like I'm going to give out. I feel like my back's going to give out. Legs are heavy. Guarantee you that's a fine. Or they could have been a smoker and they clog arteries. They present the same way. So that is a tough one. It can even feel like restless leg at night. And the treatments are tough as well. Because you got an epidural. Is it great for that? Well, it is a pitch nerve. It's always something to try. There's always a surgeon. Nobody wants that. And what a surgeon would do is they would basically chop out bone on one side here and another side. It was not a good picture to explain, but they decompress it. And so they're just taking bone out. Now, what are our choices? Well, if you get relief with bending forward, then I can mimic you bending forward with a spacer. Or I can take chunks of the ligament out that is getting thicker, narrowing the center hole. A lot more difficult to conceptualize with that spinal model. It would make a lot more sense. But just know there are other options. That's the whole point of this. You don't have to be limited to just a surgeon chopping out that bone, that bone, this entire thing. So here's a picture of us putting a spacer in. So we put this big device in, and if people come and say, you know, that heaviness feeling in my legs when I bend forward does feel better, walk further. We put this butterfly spacer in, and we literally use an X-ray to guide us. Everything you do is an X-ray to guide us. You make an incision the size of your thumbnail, and you put that thing in just like that, and deploy it. And people feel great at it. Go on that day. Most of the things, the difference between the surgeries that I do is I people go on that day, or at least I hope they go on that day. This is the other chunks of the ligament that I was telling you about. So right there, that darkness, that's a ligament. And so that darkness is pushing and narrowing things, and that can cause that narrowing of the center of the hole. Well, what I can do is also go in there with another device and literally take chunks, and this image is green, take chunks of that thickened green ligament out. And even just taking 2 or 3 little chunks out relieves enough of the narrowing where people feel a decent amount of relief. All right, back pain. So this is something we definitely need to go through because I really want you to know that. You got large joints, small joints, like this. So large joints, that big SI joint that I talked about, right? So when people come in and they have pain when they stand in one spot for a long time, doing dishes, cooking, usually they're a little obese. That's because that joint right there is the last line of defense for all your weight. And it usually gets degenerated in those people. And it would feel like pain usually in the butt, lower down. So that, I like to tell people, that's your large joint. And so what we do is we just take a needle and stick it right into that joint, and we give them steroid and some numbness. Now, sounds like a lot of stuff I do is a steroid, right? Now, let's get into the small joints. I want you to keep that large joint in mind. So the small joints of your back, they're called your facet joints. This is a major, major, major problem that a lot of people have come through with that have back pain. And usually this pain is worse with twisting and any kind of movement with that twisting, leading, rapidly sweeping, ball. Okay, so what are we going to do about it? So the best picture I could find of this joint is right here. There's another one right here. Between that large joint I showed you down here, and these little, tiny little joints called facet joints, which are on both sides at every level. You got pain with standing for long periods, pain with twisting in your back. Well, what are you going to do? What movement is left over? What are you not going to have? So these people are hurt. Now, you can't stick a needle in that joint and put steroid and expect it to work. It's not going to work. It's not going to last because that joint is way too small. So what I'm about to explain to you is a way we take care of joint pain that surgeons send us patients that they can't operate on. This is the meat of why we are creative in how we treat patients. So when we can't figure out a way to make someone feel better, let's say there's a joint that's been operated on 50 times and they still have pain, what are your choices? What we do, and we do this by cadaver studies, we go after whatever sensory nerve that connects to whatever area. So let's take the hip joint, for example. Okay, the hip joint will have a hip replacement, or what happens if the surgeon doesn't operate? What we do is we find the nerves that control the outflow of pain. They're not big nerves, they're tiny little things the size of a hair. And our job has been for years to find those nerves with cadaver dissections. Once we find those nerves, or any nerve that we're targeting, we put it to sleep for 6 hours with nothing else as a test. Okay, so what happens in that 6 hours? What did your pain do? Did it go down? Did it not change? In that 6 hour window, during that test, if your pain goes down by 50 to 80%, that's a success. So the next step is burn that. It doesn't. So what that's called is radio frequency ablation. And it's not really burning, it's more like taking insulation off the wire. You don't want to destroy a nerve. But when we pick the right nerve and you learn where they live, put that needle in the right spot, oh my goodness, the relief is awesome. This is one of the things, one of the procedures that I do for people every day, and I wish I could do it for free, and I wish I could do it for a large majority of the U.S. population because it's that incredible. And this is me ablating those tiny little nerves of the section. This, you can't really see it on this X-ray, but right at the very tip where you see kind of that angle of that needle, that's where it heats up. And, you know, it sounds scary, sure. What if you get, you know, my spinal cord, if I'm paralyzed? We're not going to paralyze you because we're nowhere near your spinal cord. We have an X-ray to guide us, and I do tons of safety tests before I put any needle. So it is safe. Now, the relief that comes with this is on average 14 to 15 months. The prior generation of pain doctors told you at 6 months. Why? What's the difference? Well, as time has gone on, we know more and more cadaver studies to really elucidate where that lives for whatever joint that it's hard. So when I do this to treat arthritis, that's what it's treated mostly. We can do it in the neck, we can do it in the knee, we can do it in lots of spaces. But for the low back, it is probably the most rewarding because people are crying during the nerve block, crying tears of joy because they have had back pain for so long. You put them all to sleep, and they're like, "Oh my gosh." Sad part is it's only going to last for about 46 hours. But the end goal is the ablation. And when you do it and you put it in the right spot, it works. I'm going to skip some of this because I'm running out of time, guys. Because I really wanted to tell you all about that. We'll just talk about some pictures really fast. So when you have disc issues, right here, this person's disc is bad. So long story short, we took this device, we stuck it into the back of the bone right here. We stuck it into the back of the bone, and same concept. Okay, so someone has pain from the disc, they don't want to see a surgeon use them and take the disc out. What are our choices? This is called a basovertebral nerve ablation. There's a nerve that's in that bone, and it has a trunk right here, and it shoots off branches, tree up and down. And so when you have a bad disc, it's got to tell your brain it hurts somehow, and it's via a nerve. So we literally go after that trunk of that nerve here and here. So, and we burn, so that thing heats up. It creates a spherical. That person is doing excellent. Here is an ablation of the knee. So steroid injection doesn't work, stops working. Okay, what are the choices? Go after the nerve that controls it. exactly what we do. Sad part about this is some of these things that I offer, insurance, it's not all considered an experiment. Okay, at some point in life, it was an experiment, but it's not anymore. You can ask the veterans that I do this for, see if they think it's an experiment. So then you got weird stuff, other back surgery. You had back surgery in the past, you still have pain. What are we going to do? We have a compression fracture, which I will show you. So this is spinal cord stimulation. But if you got back surgery and still have pain down the back or in your back and your legs, your chance of having another back surgery goes up by 50%. If you have 2 back surgeries, your chance of a third up by 50%. It just keeps going. So how do you break the cycle? Well, as long as you're not having some weakness where I really need to send you to a surgeon, we can break that cycle with something called spinal cord stimulation. What is that? This has been around since the 60s. So this guy had back surgery. What we're doing here is we're taking an epidural needle and we're not going anywhere down here where he had his back surgery, but we're going to T12L1. At T12L1, we do an epidural, and through that epidural needle, we're putting this wire that has these metal contact tips. We take that wire and we drive it all the way up to about the 8 points. It's a little different than this guy. But we put one wire and then I put a second right beside it. The reason we're doing this is spinal cord stimulation, all the pain from the legs, the back, it's got to go up those nerves into your legs and then it converges. The thoracic spine in your spinal cord. It travels up the back of your spinal cord to your brain to send those signals. So what these metal contacts do is they create a very specific electrical field around the back of the spinal cord where those nerves converge. And they ultimately trick your spinal cord, and so your brain doesn't know that it's hurting. It's like thinking of it like cutting the signals off the fence. Now, it either replaces painful areas with tingling, or it just simply decreases the pain. And the newer versions of this are just simply decreasing pain. Might not be 100%, but it does work. And it's an implanted device. So it's like a pacemaker that controls your pain. You talk to it with a remote, turn it up, turn it down, blah, blah. But I would never want to implant some hunk of metal in somebody without knowing it works. And so what this image is a test drive. We put the wires in and send you home for 7 days. At the end of 7 days, you have to tell us it's the best thing since sliced bread. Only then do we implant this device or this one. That's just the battery. You have it under your skin all the time, nice and people love this when you pick it for the right person. Don't just do this for everyone. It's terrible for arthritic pain. That's where the nerve burning procedure is coming from. So here's another version of a stimulator. So this is a dorsal root ganglion stimulator. There's little holes where the nerves come out. I think this one was this patient had a traumatic foot injury. Terrible pain in the foot from a car accident. So we put 2 of these in on the left side, and she's got close to 95% relief right now. So then last but not least, this is a kyphoplasty or a vertebroplasty. When a lot of old people, osteoporosis type people, they can have compression fractures. So what is a compression fracture? The vertebrae, I'm just going to side picture. So a compression fracture is when this vertebrae fractures. It can happen if you are in a car accident. It can happen if you have osteoporosis and your bones are thin. It just collapses. We measure it as percentage that it collapses. So if it's painful and we want to treat the pain as well as stabilize that fracture, we literally just take a big old device like this under X-ray. Access your vertebrae similar to that other disc burning procedure, and we inject cement to stabilize it. Now, that can immediately help people's pain, but it also stabilizes fractures. Now, I am totally out of time. That's my wife. That's my kids.
The surgery, the baby weight. I would love to answer the question. Yes, that was a lot.
Is it a good idea if you have an underlying medical condition to suppress the pain? This isn't pain, this is when I'm not eating wrong. Isn't that a signal that something's wrong? If you suppress the pain, you might be avoiding serious medical condition.
And that's a great question. I would say the answer to that is no. I wouldn't worry about it. And the suppression of pain is only to a point at which it's your chronic level of pain. Now, when you have some serious medical condition, there should be other ways of noticing whether or not that medical condition needs to be treated. But pain is just the first signal. It doesn't have to be, it can also be a signal that avoiding cry.
Is bone on bone not something you can fix? Because I have bone on bone fracture. You got to get it artificial. Nothing to do with it. Is that accurate?
Great question. It all depends on what the bone on bone truly is from. If it's from trauma like hockey, then, or a car accident or something like that, then that's different. But right now, I'll give you that knee picture I showed you, for example, right? That is something that we do for bone on bone because steroids are not going to work. It's too far gone. The gel. But the ablations work for anybody, usually. And it's a good option even for surgeons when their patients are too obese. They need a replacement of a joint, whatever joint, but they don't want to set them up for failure. They make them wait first. And they send them to me to help the pain. Oftentimes, they don't even want the surgery. Now, to answer your question further, I'll get to that in a second, but there is research coming out, and it's good stuff, and I was part of these research studies where we literally are able to formulate different chemical modulators, is the best way I can describe it, where it has been regrowing cartilage and dropping pain from, I'm talking really, really obese people with super bad bone on bone, 10 out of 10 pain. They're at 1 out of 10 on follow-up. And the further studies are showing that there is increasing thickness on MRI cartilage, which is kind of unreal. So the future looks bright is the only way I can answer that. Yes.
So, it's TMI, but I'm actually told I need a vaccine.
Oh boy.
So,
I've got cards.
Give a card.
I've got cards.
Start the process right now.
Yes, I would. For anybody that needs surgery, any kind of surgery, in my opinion, is to get 2 surgeons' opinions and see if they are congruent. And if not, keep trying. So, yeah.
How do you feel about conversion tables? For an adult, for normal healthy.
So what you're asking? Sorry, you had a question too.
I'm sorry.
Get to you. I'm sorry. You've been up first. Let me get to you.
Yeah. That's my question is the regenerative experimental things, right? Like, so different, like, I know they've been using ERP and stem cell injection for a long time. Is any of it showing the promise?
No, not really. The only stem cells that are worth it are the ones that are I'll take that back. There's if there is one regenerative therapy that is going to be promising, it's stem cell therapy, but not all stem cells are created equal. It still needs work. And it's not cheap. Insurance won't pay for it. And so nobody has money for this stuff. That's the same problem with PRP. I have a PRP machine that we purchased that I wanted to offer for people. It's sitting in my office and it has been for 8 months. Nobody has $800 per pop with the guarantee of what? We don't know if it's going to work. So these applications are good for certain things.
Are you seeing results? When you do get to do it?
Whenever I can find somebody with money. That's the problem.
Well, that's the whole problem with medicine in general, is you don't get to decide. You get to decide what techniques get done with you. Some bureaucrat with a profit margin in mind gets to decide.
And you could take that a million steps further. The because that treatment that I told you with the ablation for people's low backs, I told you I should do it for free. I'm not joking. That's something as a charity, as a charitable group. I truly believe it's something we should be able to provide people that need it for free without all the drama. I didn't even tell you about half the drama. That test nerve block that we do, we put those joints, any joint, to sleep. Not only do we have to do it one time. If it works, I have to do it a second time. That's 6 to 8 needles. That's a lot, guys. And for what? I already proved it once. I can guarantee you my clinical skills are good enough to I would have gone to just an ablation, skipped all the testing, and it would work. Because you see the problem, you do an exam, it matches. It's not hard. It's got to be demystified. That was that first slide I showed you. And even primary care doctors, guys, they don't understand this stuff. Sometimes even the surgeons don't understand this stuff, and that's scary. Yeah, I know. But yeah.
Physical therapists do dry needling. Is that similar to what you're doing?
Totally different. So, and this goes to your question about inversion tables. So physical therapy, inversion tables, chiropractic care, all those things are lumped as conservative management. You have to try that stuff first before insurance pays for any of that stuff that I showed you. And so, sure, I think for low back, I don't think it's worth it. Though I do believe that those for the neck, it could be worth it in terms of pulling your neck up if you have shooting pain down your arm, because when you do that, it makes more room on the side hole exits with nerves in that. Yeah.
I have a friend with chronic shoulder pain due to a pickleball accident. But do your techniques work for upper body compressions, entire shoulder?
Yeah.
Post doesn't get
that technique is
upper body.
Yeah, that technique is good. The technique of targeting the nerve, and if we put it to sleep and then you burn it, that works for a lot of joints. Shoulder is the toughest one. Hip is second toughest, but we've pretty much closely conquered the hip. The shoulder, I can do one nerve out of 3 or 4, but those other 3 or 4 control muscles as well, and that can make you weak, so we don't go after them. The shoulder's a tough one. Yes, absolutely. But hey, even if you go after one nerve, you put that nerve to sleep, you get your answer. That's what it should feel like. Yeah. So we're done. Okay. If you guys have any questions, here's my card, and definitely write down my email. Just shoot me an email, and Steve has my contact information. You don't need you do need an appointment to see me, but you can just go online. You don't need a referral. So go to Wake's website, just Google it. Follow.
All right.
Thank you.
Ticket is 074.
Thank you for your phone.
Black.